Out. I've gone out. What is that? No. I'm out.
Okay, greetings and welcome to another SJMC Grand Rounds, and this time the cardiology team is presenting. And before I pass on to the moderator, I just want to take you through some housekeeping slides. Like always, all our sessions, the discussion will be on Slido, and the code is M087. If you open Slido, the Q&A will be at M087. So we hope you're using two devices, one to watch the presentation and preferably your phone to scan and participate in the questions and answers, which will be the end of the talk. Okay, and also you'll be claiming CPD points by scanning with the MMA app, which will be scanning for points using the QR code, which will be displayed at the end of the talk. Okay, it will be displayed in this slide. Okay. All right. So now I'm going to pass over to the panelists. So I'm going to pass over to my colleague, Dr. Jayamala, consultant cardiologist, who's the moderator. Okay, over to you, Jayamala.
Okay, thank you very much, Alan. Actually, the moderator this time would be FP Chan, but we seem to be missing. We seem to be missing one of our colleagues, our esteemed colleague, Hugh Fan Lee. Has he forgotten to come? I hope he's around.
Okay, hang on. Where's Fan Lee?
Fan Lee, are you around? There you are. Hi. Okay.
Good afternoon, all.
Right. Okay. I'm sharing as Chan slides now.
Okay. Good afternoon, everyone. Nice to have you join us. Right. So I understand that we are supposed to finish on time. So this afternoon we are going to have a conjoined grand round that will include the endocrinologist as well as the cardiologist. Okay. So these are the people involved, myself and Hugh Fan Lee, endocrinology, and you've got Jayamala and Dr. Cole Cotway, cardiologist. Okay. So the title of this symposium is actually Masquerader or Heartbreaker. So let's start with case number 1. Dr. Hugh, this is a 42-year-old woman who presented to her cardiologist with palpitations. She's worried about her heart because her father had a heart attack at the age of 50. And the last 3 to 6 months, she's been having palpitations, she's breathless on exertion, and she says prior to this, she's very fit. until the MCO, she was able to exercise, but since then, unable to go out, she cannot sleep, she's been losing weight, and she blamed it all on the MCO. When she was seen in the emergency, weight is 46 kilograms, BMI 20 kilograms per meter squared, appears 110, 120, regular, blood pressure as seen there, thyroid just palpable, nothing else. Nothing else to be seen. And her ECG shows sinus tachycardia, echocardiograms was normal, and these were the thyroid function results found. 51, free T4, 20. For those of you who are not familiar with the normal ranges, I put it on the side for you to see, right? Dr. Hugh, what other history will you elicit from her, and do you think she has heart disease? How will you manage her?
Well, the fact that we have the thyroid function test obviously takes the game away. But I suppose it's somebody who has got a escalating symptoms of palpitation and then weight loss, and particularly somebody who is not in an age group that would have a high risk of ischemic heart disease, then you certainly would need to look at thyroid being a possibility, particularly in a woman. And the weight loss would suggest that. And I suppose from the history, you will want to see, because a lot of the symptoms of thyrotoxicosis are positive symptoms. Very, very often, patients actually be able to identify almost down to the week when the symptom starts. You know, whether she has tremor, whether her appetite is very good. Despite the good appetite, they still continue to lose weight because of the metabolism being very, very high. Now, of course, the other issues really relate to her periods, because somebody who's 42, really not a menopausal age, you want to see whether there's any period disturbance, and we know that thyrotoxicosis can cause period disturbance. So it will come together as a symptomatology that would actually indicate that this is thyroid. This is ischemic heart disease, obviously, it's rarely going to affect your period, and the tremor is often not related to the heart problem.
So do you think she has got heart disease? Does she belong to the cardiologist?
I don't think she has heart disease, particularly with the thyroid. But of course, you want to make sure the palpitation is not due to arrhythmia. You want to make sure that she doesn't have heart disease secondary to a thyrotoxicosis that seemingly from the history has been going on for a while. We do know that thyrotoxicosis lasting for a long time can actually give rise to cardiac complications.
So she does not have a history of heart asthma, so she's given the classic thyroid carbimazole 30 milligrams once daily. And so, but if she said she had a history of bronchial asthma, do you think propranolol would be appropriate, or perhaps would it be something else?
Well, I would really want to elicit the history of her asthma, whether she needed any bronchodilator treatment over the last few years. If this hasn't been treated, in fact, her asthma has been fairly well controlled, or rather, don't need treatment, then propranolol probably will not be contraindicated. But of course, if she has frequent asthmatic attack over the last few months, particularly, then propranolol probably I will go easy, because propranolol is probably the most effective treatment for her palpitation, because being that very dirty beta blocker, if you have got just a beta 1 blocker, then the palpitation may not be as well controlled.
Her pulse is running at about 110, 120. So if she does have frequent asthmatic attacks, is there any other option for you to slow down her heart rate?
Short of beta blockade. Well, I suppose you can use a more specific beta blockade that doesn't cause bronchial asthma or exacerbate bronchial asthma. But the problem is some of these may not actually as good as slowing down the heart rate, and they may still get palpitation because of that.
Okay. Yeah. Thank you very much. You know, as a general rule of thumb, could you just give the doctors who are listening in some practical tips how you manage a simple, straightforward, newly diagnosed thyrotoxic patient? Okay.
Well, I think the fact that the patient will start with 30 milligrams of carbimazole was a good start. I noticed that some people start with a very small dose. Somebody who present for the first time, obviously the T4, the thyroxine level is very high. You need to hit them very hard. with high doses of carbimazole, so they can actually bring it down very quickly. It's not only just to control the symptoms earlier and quicker, but despite the fact that you say earlier and quicker, it does take a long time. The reason is T4 has got a half-life of 8 days. So even if you shut down the thyroid thyroxine output from the thyroid gland, you still need at least for her 2 half-lives before it comes out, and that is 16 days. But of course, we do know that big doses of carbimazole will not shut down thyroid output completely. So you will still need 3 to 4 weeks before the T4 would come down. In fact, some of the patients that I have seen with very high level take up to 2 months before it comes down to normal level, right? So because carbimazole, there is, or any thyroid medicine, it applies to methimazole as well as propylthiouracil, the side effect profile are very similar. So allergy is a common side effect. We need to tell the patients that watch out for urticaria or rashes that is made worse by starting on treatment. But we do know that thyrotoxicosis very often causes itchiness in the skin. So sometimes patients may not be able to differentiate whether it is the drug itself or the disease itself. But urticaria is definitely not the disease. It's very often due to the drug. And of course, you need to look out for neutropenia or anti-thyroid medication. You need to warn them that if they have high fever and bad sore throat, they really need to see the doctor to check a white cell count to make sure this is neutropenia. It's very rare, but it's life-threatening, and if we can actually get patients to watch out for it, we can actually reduce a lot of morbidity and mortality even, right? So
when do you consider cutting down the dose when you start with a high dose? Just a ballpark figure?
Well, at least a month or 2. In fact, a lot of the time I don't check it in a month. I just see how they respond. If they pick up their weight and they are symptomatically a lot better, I may actually start to tail down the carbimazole without doing a thyroid test. I'll probably do it in about 2 months' time, actually, having reduced the dose at least once.
Because I think a very common mistake that we come across is that doctors tend to keep these patients on high doses and patients are over suppressed, right?
Yeah.
Okay, so let's move on to part 2 of this patient. She's lost to follow-up and returns only 10 years later. So that's now, she's 52 years old. She's presenting to the emergency room, breathless, ankle swelling, 6 months, still skinny like anything, pitting ankle edema, JVP grossly elevated, pulses 120, blood pressure is written there, heart is big, and she's got crepitations with an enlarged liver. Dr. Jaya, you are asked to see this patient because she's unwell. What do you think is the current problem, and what will you order, and how will you manage her?
Obviously, she has got cardiac failure. And if you look at the signs, it appears as if the right heart signs are far more than just the lung signs where there are only few basal crepitations, which is a common finding in patients with thyrotoxic heart failure. How will I manage her? Well, number one, what test would I do? Of course, I would like to do an ECG to confirm that it is she doesn't have any other cardiac pathology. Number 2, chest X-ray, show you the amount whether she may have a pleural effusion and stuff like that. And if possible, a bedside echocardiogram, which will tell me immediately what her LV function is. How will I manage this patient? Obviously, she will need diuretics and something for ACE inhibitor. And once she's out of heart failure, that's when I would introduce a beta blocker. Now you have jumping to ask me, did I perform an echo and what would I expect to find in an echo? Okay, yes, I did do an echocardiogram. And if I can have the next slide, I would be able to show you. Okay, this is her echocardiogram. And all right. Okay, that's the echocardiogram. And what she has is, okay, there's a bit of mitral regurgitation. Her LV and her LA are both dilated. Now, this is a 4-chamber, and it can show that the right side of the right ventricle appears bigger than the left ventricle. This is a finding that we sometimes see in patients with thyrotoxic heart failure. And if you look at here, this is a short axis view, and you will see that there's flattening of the intraventricular septum. You would expect it to be round, but you see it's flattened, which indicates to us that the pulmonary artery pressure is maybe elevated. Next slide, please. Okay, this is just to show you, yes, her LV is dilated at 64 millimeter, and her ejection fraction is, depending on how you measure it, between 42 to 39.1%. So that's what ejection fraction is. So she's got biventricular heart failure. Next slide.
So the question that I asked is there any difference in treating the heart failure of heart due to ischemic heart disease versus the thyroid cardiomyopathy?
Well, in terms of the heart treatment as such, although you still use diuretics, ACE inhibitors, and beta blockers, if it is due to thyrotoxicosis, I would tend to bring up the beta blocker at a much faster rate than I would with an ACE inhibitor. So more emphasis on the beta blocker rather than on an ACE inhibitor. And the second important thing, cardiac failure is just a diagnosis. We need to find out the cause. So in this case, it's thyrotoxicosis. So I would not go on and look for other cause, doing an angiogram or something like that to look for coronary artery disease.
So after managing her acute illness, she's discharged. Dr. Hill, what is your long-term plan for her hyperthyroidism, and could she have avoided going into heart failure?
Well, perhaps I'll answer the second question first. I think somebody who has had thyrotoxicosis, having completed at least 18 months of antithyroid medication and it's been stable, once you have stopped it, the recurrence rate is about 50%. So that means there are 50% of those who will never need to have any further thyroid therapy. But those who are recur, or the 50% who recur, the moment they recur, subsequent recurrence is almost 100%. So therefore, somebody who has one recurrence, she should be on lifelong antithyroid treatment as one option. Okay? So therefore, if she has been taking antithyroid therapy, there have been multiple relapses, and she's been told or advised at least to continue on a very small dose of maintenance antithyroid medication to keep her euthyroid, this wouldn't have happened. Now that this cardiomyopathy has happened, we do know that some of these patients, when the thyroid euthyroidism has been restored, sometimes the cardiomyopathy actually improves. But in any case, she would be at high risk of developing heart failure again if she's allowed to become thyrotoxic. So to rely on her to take medication long term would be probably a big ask. I would actually look at definitive therapy. Definitive therapy in terms of radioactivity to at least once and for all treat the possibility of recurrent thyrotoxicosis. But of course, there is a risk of hypothyroidism, but the treatment of hypothyroidism is very simple. We only give thyroxine at the appropriate dose, and it doesn't have any side effects. Now, this would make sure the thyroid status is stable, and secondly, the recurrence of cardiomyopathy or due to thyrotoxicosis can be averted and prevented.
Dr. Jaya, is there any teaching point that you would like to make for this particular patient?
Well, if a patient presents with heart failure, always remember that thyroid is a very treatable cause. Look for it.
Okay, fine. Is that it? Shall we do number 2? So case number 2 is a Dr. Jaya
is a 65-year-old man who comes to ER with breathlessness and near fainting spell. His weight is 57 kilo, height is 165 cm, and pulse 140 minutes, irregular. Blood pressure is as shown. There is signs of heart failure. JVP is raised. There's minimal ankle edema. There's an S3 gallop and bibasal crepitations. Okay, this is his ECG. Dr. Koh, can you please comment about the ECG?
Okay, thank you. So before the ECG, they see a patient with a fast pulse rate. Feel the pulse, palpate the pulse. If the pulse is fast, then you have to take note of the regularity. The patient has a regular pulse, then most likely we are dealing with something like a tachycardia, a sinus tachycardia. If the patient has a occasional mid-beat, then probably we'll think about a premature atrial contraction or premature ventricular contraction. Now, as mentioned, in this case, it's irregular. If you feel the pulse and it's fast, irregular. Clinical practice-wise, even before you do the ECG, you know that this patient almost always they present with the atrial fibrillation. Now, if you look at this ECG with that clinical in mind, what you can see that the RR interval is not regular, irregular. The R wave over here is longer, and this one is slightly shorter, and the distance between this R wave and this R wave even further apart. So now you have irregular, you have confirmed very irregular RR interval. The next is you look at the P wave. If you can't see any regular P wave before the QRS complexes, I can tell you that almost 99.9% you're dealing with atrial fibrillation. So this patient has atrial fibrillation with a rate of probably about 130, 150 beats per minute. Now, what I want to teach you all is, apart from looking just the rhythm, look at in between the rhythm, which is in this case, you look at the ST segment of the leads. V4 to V6 has a bit of ST depression, and look at the QRS voltages, they are very high. So there's a bit of LVH criteria has been fit. So even before doing echocardiogram, you know that this patient has, apart from atrial fibrillation, has some form of cardiomyopathy. All right.
Now, is it normal for someone just coming in AS and a normal heart to go into heart failure?
Yep. Most of the time, it is unlikely to have a normal heart, unless he has been having this fast atrial fibrillation for some time. This condition is called tachycardia-induced cardiomyopathy. So if someone has a normal heart, went for checkup, suddenly goes to heart failure, is very unlikely. So as I said, from the ECG itself, it's pointed that this patient has some form of cardiomyopathy. Clinical-wise, ankle edema, raised GVT, and this patient certainly has congestive cardiac failure on presentation.
How will you manage him?
So standard management, like in the first case, probably first we'll relieve the symptoms. We'll reduce the preload and afterload. Usually we'll use dialysis, the mainstay treatment for acute heart failure. And if the blood pressure is okay, then what we'll do is to give a bit of a nitrate infusion. We'll release a bit of the afterload. And if the heart rate is not too bad, next is the rhythm. Sometimes we know that diagnosing a heart failure is easy, but what triggered it? So it can be a rhythm problem itself triggering it. It is going to fast atrial fibrillation. So we control that. And to control the rhythm, I think most of us will use agent that has very effective and fast onset, which is the IV amiodarone. Because the first effect of IV amiodarone will be the beta blockade effect. And on top of that, they also have a rhythm efficacy. We can convert an irregular rhythm, the atrial fibrillation, into sinus rhythm. And importantly, another trigger that we always have to screen is whether this patient has any infection. All right, whether the patient has pneumonia, URTI, and of course, particularly for this topic, always screen for a thyroid function test. Right, we know that thyroid function can present as a heart failure, especially when the weight is low BMI, skinny particular, with a history of palpitation on and off for a long time.
Okay, so this is what their thyroid function test. So will your cardiac management, how are you going to control the EF rate? You haven't told me that.
Yeah, correct. So as I said, we have a love-hate relationship with the amiodarone. On one hand, we like amiodarone because it's very effective in controlling the rhythm and the rate. On the other hand, there's a lot of side effects. So I think most of us will use IV amiodarone to control the rate and the rhythm, to push it a bit lower, but have to be careful. We cannot push the heart rate too low because it will decompensate the heart failure more. So number one, I'll use the amiodarone. And if I look at this thyroid function test, then I'll be a bit more cautious. I may not want to continue with the amiodarone. I will probably just use a beta blocker to control the weight after this. So the cardiac management is a bit different. If I don't see this kind of thyroid function test, probably I will complete the IV amiodarone plus giving a bit of maintenance. One of note, particularly in atrial fibrillation patients, every time when they convert back to sinus node, there's a bit of risk of getting a thromboembolic stroke. So we always have to give low molecular heparin or the new oral anticoagulation as a preventive measure for a thromboembolic event.
Okay, moving the next. Okay, Dr. Hill, what are the principles of management in this patient, and what would be his long-term management? Basically, somebody who came in with AF, heart failure, and found to be thyrotoxic.
Well, obviously, the treatment activity is really to bring down the thyroid, the excessive thyrotoxicosis as quickly as possible. Again, as in the case 1, give high dose of antithyroid medication, and if possible, beta blockade them to reduce the symptoms. But of course, the issues is not just about what happened now, but also in the future. Now, this case is slightly different from case 1 because this is an older man who already have a higher risk of background of ischemic heart disease. So we do know that thyrotoxicosis itself exacerbates ischemic heart disease. More likely to get angina, more likely to get ischemic events during thyrotoxicosis because of the hypermetabolic state of thyrotoxicosis induces. So therefore, in somebody who have heart complications, be it from just thyroid itself or exacerbated by the thyrotoxicosis, you want to long-term looking at definitive therapy again, making sure that thyrotoxicosis doesn't come back. You know that, as I mentioned in case 1, if they are treated after 2 years, even we stop the medicine, the recurrence rate is 50%. And you know how many heart failures can you have before the patient dies? So I mean, the more heart failure you get, the more likely the risk of mortality and morbidity increases exponentially. So it is probably important not only to bring down the thyroid acutely, but also maintain them lifelong.
Dr. Hugh, can I just interject here? You noted the potassium is 2.7, and are you surprised at all that he has no palpable goiter or any signs that you and I recognize as hyperthyroid?
Well, okay. Well, I think a goiter may not be directly related to function. There are a lot of people who are really thyrotoxic and very little goiter. And there are people who have multinodular goiter and thyrotoxic is absolutely normal. So the goiter size is not a good judge of the thyroid state. And in fact, a lot of patients who are thyrotoxic, if you overtreat them and become hypothyroid, the goiter actually becomes worse. So therefore, the goiter would indicate something is wrong, but it doesn't tell you the function. Neither does it tell you the severity of the dysfunction.
Does the potassium level worry you?
Yeah, certainly. I think in somebody with thyrotoxicosis, it's quite common to get potassium, especially in men. In fact, there is a condition called hypokalemic paralysis that seems to be more common in Oriental, in Asians, compared to other races. And that is due to hypokalemia that's causing paralysis. And it's been indicated, sometimes cardiac arrest is indicated in those with hypokalemia. So that hypokalemia needs to be sorted. And the risk of hypokalemia disappears the moment you restore normal thyroid function.
Okay, call again. Will this man's AF resolve? And if his AF persists, what is your next step?
Okay, before I answer this, can I just go back to the previous question because very interesting. The thyroid in practice, the thyroid function probably not won't come back so early. So if I've been given diuretics for this patient, I've been giving amiodarone for this patient, and I noted the potassium of 2.7, I'll be very scared because this is a cell for total disorder. So total disorder is a polymorphic BT, particularly if you have a prolonged QT, especially in the structural abnormal heart. Then you are giving this kind of amiodarone which prolongs the QT, hypokalemia prolongs QT, diuretic prolongs QT. So most of the time when I see this kind of potassium, I will treat it very aggressively as well. Because I know that, the amiodarone, once I loaded, it will be there in the body for some time, and then we'll monitor it. Okay, so this is the one important point, especially for those cardiologists who manage this case. Now, will his AF resolve? Okay, The honest answer is nobody knows. So most of the time when we talk about patients with AF, then found to have thyroid toxicosis or hypothyroidism, we think that is just one trigger point that causes the AF. But nowadays we know that this kind of, the thyroid in causing a lot of these molecular level changes, atrial myopathy, ventricular myopathy, and the AF might persist later on. So to be safe, I will probably anticoagulate even when I first see this patient, especially the patient in the high risk group, 65 years old, issue of hypertension, definitely I will anticoagulate. And if you ask me what are the embolic risk stroke, I will always use the Chapman score. You know what is the Chapman score? The C stands for congestive heart failure, hypertension, the age, issue of stroke, any issue of vascular disease, and all this. If the Chapman score is more than 1, the risk starts from 2% per year, and then it goes on. If the Chapman is 3, then about 3 to 5% per year. So yes, if in a very high risk group, I will initiate the anticoagulation, and whether I will continue on, most likely yes, even the thyroid function has been controlled. If you're talking about maybe a younger group of patients, let's say 20, 30 years old, without any other risk factor, perhaps I will still do the same thing, anticoagulate first. A bit controversial, but we know that we see a lot of patients that first presented with a stroke, young patients, Chapman 0, they got a stroke because we know that hyperthyroidism itself is a coagulopathy. I'm not I don't know whether my endocrine colleague will agree with me. Do you see that often, Dr. Chen, Dr. Hugh? Those with AF, young patients presented with stroke.
Yes, actually, in fact, they either present with stroke or they get a stroke soon after. So it is certainly a problem that concerns us, and anticoagulation sounds like a reasonable option, especially until you can be absolutely certain that the AF or the proximal AF doesn't persist.
All right. So this group of patients, the problem is not the short-term anticoagulation. I think most of us will anticoagulate. The only problem is the long-term, whether you need to continue beyond 1 year or beyond. The thyroid function has been controlled, and I will say that probably based on case-on-case basis.
Okay, so this man does not want radioactive iodine, although you have advised him to do it, Dr. Hugh. So what can you offer?
Well, I think you have to explain to the patients why the radioactive iodine was suggested and the side effect of radioactive iodine. The moment patients look at the word radioactive, they think they're going to turn them into a monster. I think the only side effect we know of radioactive iodine is hypothyroidism. There's a 50% risk, which is high. But the treatment for hypothyroidism is actually very straightforward. Just replace with a medication that doesn't have side effects. But the alternative, not taking radioactive iodine, and so therefore you rely on patients taking anti-thyroid medication, and it is a bit of an ask to make sure that they are compliant for the rest of their life without even intermittent poor compliance. Because we know that in patients, there have been studies that show that even in patients who actually has been compliant with therapy, about 5% of them, the thyroid function does swing. And in those who swing and actually gave even a short time frame of thyrotoxicosis might exacerbate heart failure, might exacerbate AF, and therefore the risk of embolic stroke is what we spoke about just now, and all these escalate. So therefore, in terms of reducing long-term complications and morbidity and mortality, both of them, radioactive iodine is probably unmatched in terms of their efficacy. But if they don't want to take it, then they need to understand the risk they're putting themselves through, even with good compliance.
Okay, let's go to case number 3. Dr. J, get ready. This is a 62-year-old woman who came with breathlessness, ankle swelling. She'd had a thyroid removal for multinodular goiter, and on direct questioning, she says, you got fed up of taking the thyroid medicine long ago, decided to drop it. When she comes in, her weight is 78, so she's obese. Pulse is 64, blood pressure is 150 by 70, all right? So what do we have here? Her investigations show this. Her cholesterol is very high, T4 is low, and the TSH is grossly elevated. She had a chest X-ray done. Dr. Jaya, would you like to comment on this? Is it Dr. Jaya or Dr. Ko? I'm so sorry.
Jaya is comment on it. Yes, it's a very large globular heart. And when you see this sort of globular heart, well, it could just be a cardiomyopathy, or you must always have a back in the mind whether this lady has got a pericardial effusion, sometimes a finding in hypothyroidism.
So in fact, she had an echocardiogram done, Dr. Jaya, and it does confirm that she has pericardial effusion. I didn't manage to download that, but this is her ECG. So she doesn't complain of any chest pain, just breathless on exertion. This is her ECG.
Well, it shows sinus bradycardia and very non-specific STT changes, which could be just be due to the thyroid. So no real indication of a previous infarction.
That she was breathless on exertion and and how would you approach her management? How would you, if she came to you asking, do you think she's got atherosclerotic coronary artery disease?
Okay, firstly, for her thyroid, I'll catch you and you can take care of it, but you're going to pass it back to me to ask, does she have any heart disease? Well, it's based on the clinical history and ECG and the echo findings. I would think she's at high risk of getting coronary artery disease, but clinically, I think at present she does not really have any evidence of obvious coronary artery disease. So if you need to start your antithyroid medicines, I would say go ahead, start slow and go rather slow.
You don't think you would be able to do a stress ECG for her?
No way. This fat woman, this edema, no way. Maybe if you really want to be sure, you really push my hand, then I would be having to do more invasive tests, which is really probably unwarranted.
Okay. So Dr. Hugh, Dr. Jaya told you, the T4 TSH look like that. Please help me.
Well, actually, she asked for you to comment. Actually, really. You see, the problem with hypothyroidism is that it actually causes hypercholesterolemia, and that increases the risk of ischemic heart disease on the longer term. Now, obviously, the higher the lipid level, the longer it's been high, the higher the risk. So from the history, we don't know how long the patient has stopped the medication for. Now, in thyrotoxicosis, the symptoms are positive symptoms. So a lot of patients can pinpoint to the very week the symptoms started sometimes. Whereas hypothyroidism is negative, so a bit cold, a bit tired, so they could have hypothyroidism for years and they may not even know it. But of course, in her case, we probably can point out when she became hypothyroid. That was when she stopped taking medicine. So she stopped taking the thyroxine replacement. That was the time when she became hypothyroid. So given the fact that she's had a few years of hypercholesterolemia, the risk of ischemic heart disease is probably quite substantial in the 62-year-old. So, and we know that by starting on a thyroid replacement, you increase the metabolic rate. And if you do have occult ischemic heart disease, you may actually bring that to open. You can actually push somebody into angina if they have ischemic heart disease. So therefore, in somebody like that, we want to start slowly. The criteria, 25 microgram, maybe alternative for the first 2-3 days. If there's no shortness, no exacerbation of a shortness of breath or palpitation or angina, then you increase to 25 microgram a day. After a couple of weeks, may increase to 50, because restoring her to euthyroidism is not the priority here, right? So therefore,
you would give her every other day 25 mics for daily, every other day for 2 weeks before you escalate.
For a week, and then escalate to 25 daily, then increase to 50. Then of course she probably need about 100 microgram of anyway.
So if Dr. Jia, if she says after starting Dr. Hugh's medicine, I'm starting to get a bit of chest pain, what will you do?
Well, then I would treat her. As for coronary artery disease, then you would do, well, she would need at least, since you cannot do a stress test, you get her to do a coronary angiogram, a CT coronary angiogram, delineate the coronary anatomy. Of course, start her with anti-anginals, which would be aspirin or Plavix or whichever, and a statin, no beta blockers, nitrates or calcium channel blockers as necessary.
Do you think she'll require statin on long term?
Yes, if she has got heart disease, yes, because you want her LDL to be less than 1.4.
Okay. Right. So you guys saved her life. She's gone home on Euthyroid 100 micrograms a day. Then one day she comes back for her follow-up and she comes with this result, Dr. Hugh. T4 is elevated above the normal range. TSH is 1.7. Clinically, however, she is still got a normal pulse and she's euthyroid. What do you think of the results? And do you think she needs to change her thyroxine dose?
Well, she has been compliant with therapy, and in fact, the thyroid function test is actually normal. With the TSH being in the normal range means that her thyroid is very stable. 3T4 as a measurement sometimes it is slightly out, but that doesn't mean that she's thyrotoxic. The thyroid state is indicated more better by the TSH level rather than the 3T4 level.
So this is actually a teaching point for the GPs, that sometimes when patients have taken the thyroxine in the morning, at the time that they have their blood test done, it will show a slightly higher than normal 3T4 because of just the initial absorption. So the teaching point is look at and focus on the one on the TSH, because that's the one that will tell you most accurately whether or not the adequacy of thyroxine. Don't panic. Yeah. Okay.
But the reverse is going to be different. Huh? So
Yes.
if you have thyrotoxicosis for a while and the TSH may be suppressed for many months, despite the fact that T4 has gone back down to normal.
Yeah. Okay. So unfortunately, she did not, not so happy with what you all have done. She defaults follow-up. And when she comes back again, Dr. Hugh, her T4 is down in the boots 3. And the TSH jumped up to 73. What will you do with this patient? What will you ask her?
Well, ask her to see a speech chart and give her a big scolding. Then she will be more compliant after that. Well, I think really is to look at compliance, look at why she's not taking her medication, whether.
But she says, no, doc, I'm sorry to interrupt you. I am taking my medicine. So she actually says, no, doc, I've been seeing a doctor at a wellness clinic, and he's given me this natural bioidentical hormone. It looks like this, doc. You know, it says thyroid extract is so natural, therefore it must be safer. What will you do, Dr. Hugh?
Obviously, it doesn't work. Otherwise, the thyroid functions will be normal. In fact, it probably wouldn't work very well. Well, some of these so-called bioidentical hormones are not constant in the amount, even if they contain thyroxine. Or if they're supposed to contain thyroid extract, has a combination of T4 and T3 as they claim, but the effect can be variable. That means this batch of bioidentical hormone may be different from another batch of bioidentical hormone. So your thyroid function may swing from hypothyroid to thyrotoxicosis. So it is in fact, it is advised from the Endocrine Society not to touch it, partly because it's unpredictability.
So I think this is another teaching point that actually bioidentical hormones, the quality control is not there. The doctors who are giving it are not, they don't know what is inside. And when you do a result, you look at this and really don't depend on these bioidentical hormones, right? So go back on your usual stuff. Okay, case number 4.
SP. So we are going on to the last case. The 72-year-old woman has had healthy patients on and off for 1 to 2 years. No other medical illness. She is not really overweight, 60, height 160, and her BP is also 140/80. When you examine her, her pulse is regular. And as a result of that, you have put her on a Holter. So the next ECG will show the Holter. Next slide, please. Okay, Dr. Cole, can you comment about this alter?
All right. Can I have the pointer, please? Okay. Let us pause for a while for the audience to look at this alter tracing. It's very interesting. Now, whenever the patient complains of palpitations and we do an ECG on spot, remember that if you capture a normal ECG, it doesn't mean that the patient has a normal sinus rhythm throughout. You only capture the particular point of time. Then when you ask the patient the history, if the palpitation coming like very frequent in the sense of every day, if it's every day, then the conventional 24-hour Holter will be sufficient to capture any suspected rhythm abnormalities. But if the palpitation like comes every once a week, perhaps a more prolonged rhythm monitoring, like extended Holter monitoring, rhythm card, will be more appropriate to capture this rhythm. Now, look at this rhythm, it's very interesting. Can you see my pointer over here? That this patient has sinus rhythm. You see a P wave over here, sinus rhythm, P wave, PRS. And what happened here is actually a premature atrial contraction. So it's a PAC. Again here, at inverted P wave, another APC, a few more that triggers into atrial fibrillation. Why I say it's atrial fibrillation here, the RR interval again, can you see, is not regular, which then later on become more regular on the third strip. Look at the first strip, the rhythm become more regular and it organizes into atrial flutter. Now, atrial fibrillation always goes hand in hand with flutter. Sometimes it goes with beat and then organized back to flutter and fibrillation. So this patient has what we call atrial fibrillation, atrial flutter kind of shield of so we diagnose atrial fibrillation based on a clear-cut rhythm documentation of this kind of rhythm.
So, how will you manage this patient's arrhythmia?
Okay, so the patient has symptoms, first of all right? And he has, for some time, presented with the symptoms. So obviously, we're going to treat the symptoms. And also, we got the diagnosis, which is atrial fibrillation or atrial flutter that's causing the symptoms. Now, how do we manage the atrial fibrillation and atrial flutter? For many years, people think that atrial fibrillation is rather benign, and the rhythm part can be just treated by weight management. But recent guidelines and trials have suggest that a rhythm control is better strategy than the weight control in terms of it can reduce the cardiovascular mortality and even stroke. So what I'll advise the patient is I will start on anti-arrhythmic medication, provided that the patient has no structural heart abnormality. I need to make sure that. So first of all, I'll do at least either a stress test or echocardiogram. If no, then my first option of medication usually is flecainide. In Malaysia, we can use flecainide or sotalol. Or in patient with a pre-existing heart problem, then I'll probably use amiodarone. But amiodarone is not a very good drug. And this group of patients, sometimes we have to offer another option called a catheter ablation for this patient. Now, before I go on, apart from managing the symptoms and of course the rhythm, another more important thing I always talk about is actually what is the risk of this patient getting a stroke. Because the impact of stroke itself is more devastating than just the symptom of palpitation. And a lot of patients, in fact, I think 1/3 of the patients that have stroke have actually atrial fibrillation. So the patient, again, using the CHEST score, 72 years old woman, definitely CHEST score is 2. And you look at the blood pressure, it is a bit on the borderline side. I will probably be cautious and ask the patient actually to measure the BP at home and make sure she's not hypertensive. If not, then I'll treat that as well. Now, CHEST 2 and above, definitely the choice of anticoagulation is definitely warranted. Nowadays, most of the time we use the direct oral anticoagulation like rivaroxaban, apixaban, or dabigatran. So that's number 2. Number 3, sometimes I also ask myself, why this patient have no other risk factors presented with atrial fibrillation? So of course, one of the things is blood pressure. Of course, aging is the most probably most common cause, and I think it will be thyroid. So Although the patient clinical euthyroid, I'll probably still send for a thyroid function test. In fact, there is a guideline. Noted the patient has atrial fibrillation, you have to send a baseline thyroid function test.
There it is, the thyroid function test.
Now we've got the problem. Yep. Then we have to call Dr. He or Dr. Chan.
Okay, Dr. Chan, would you like to talk about this?
This is a typical thyroid function result of what we in endocrinological terms say is subclinical hyperthyroidism. Subclinical, meaning no clinical features whatsoever, as you have heard from the clinical examination. No goiter, no eye signs, clinically not hyperthyroid, but the TSH is suppressed at less than 0.1, 0.01. Even if the T4 and T3 levels are normal, this constitutes subclinical hyperthyroid, and it has everything to do with her paroxysmal AF flutter fit, because we know that subclinical hyperthyroidism is associated with higher risk of arrhythmias, and it is necessary for us to treat this patient with anti-thyroid medication and normalize her thyroid function with a plan to actually give her a definitive treatment. If she's got no goiter, surgery is not an option for her. It would be radioactive iodine. If she refuses to consider it, then like what Dr. Hugh said earlier on, then you've got to knock her on the head and say, look, you've got to come back and see me regularly and make sure that your thyroid function is normalized with anti-thyroid therapy, probably for the rest of your life, right? And what other I'm going to run now, Jaya, sorry. Other concerns is if she's got a subclinical hyperthyroidism, we worry about osteopenia and osteoporosis, right? And I think in the interest of time, perhaps as a co-facilitator, we will try and answer some of the questions that have been posed on the Slido. And perhaps I'll ask Dr. Hugh first to answer this first one, which is patients with free T4 level that's normal, but the TSH above 10. What would you recommend this doctor to do?
Okay, well, assuming the patient is asymptomatic and elevated TSH actually suggests that the patient is hypothyroid. Now, for those people who have a TSH is above 10, they are unlikely to recover. You know, if your TSH normal level is up to 4.5, for example, you've got a TSH of 4.8 or 5, there's a possibility that they are actually subclinical hypothyroid, but they may actually dither between TSH elevated back to normal. If they are asymptomatic and they're not convinced and they don't want to take medicine, I will repeat the blood test in a month. But if a TSH is above 10, they are unlikely to get back down to normal and they'll need thyroxine. Why thyroxine? The reason is because of hyperlipidemia. We know that the TSH, even if slightly elevated, actually results in a higher LDL level, and because LDL is very closely related to ischemic heart disease rate, and so you don't want them to be at a higher risk. So therefore, in somebody like that, I would explain to them that the thyroid is not going to recover, and there is on the longer term increased lipid level being a risk. I will start it on thyroxine. Slowly, if they are older, because of ischemic heart disease risk, as we explained.
What kind of point TSH are we asked to decide that these individuals require thyroxine therapy, Dr. Hugh?
Symptoms, if there are symptoms, or if patients have hypercholesterolemia, then I would have a lower threshold to treat. Somebody who's younger, who has no symptoms, no lipid, I would allow a TSH to float a little bit higher, or even wait for a bit longer before the patient is convinced to take the medicine.
Yes, because you're talking about long-term therapy, isn't it?
Sure.
Do you do a thyroid antibody, autoantibody to delineate what is the cause of the hypothyroidism?
Well, I mean, it will delineate the cause. The problem with thyroid antibody is only increase it only indicates there's increased risk of autoimmune thyroid disease, but it doesn't indicate your thyroid function. There are a lot of patients whose relatives have thyroid disease, and they use thyroid, the thyroid antibody is high. So therefore, to me, thyroid antibody may explain the autoimmunity, but it doesn't guide you in your management.
Okay, so if you start the patient on thyroxine, when do you repeat the TSH? And what level do you consider that she has reached her target?
Okay, I would want to keep the TSH level to be below 4. Certainly not suppressed because you want to make them euthyroid and not over replace them.
Right. Yep. And when would you repeat? When would you say that
repeat.
to do the TSH?
I would do it in 2 months. Yeah, 4 to 6 weeks minimum. Probably 2 months would be good.
And why is it that you need to wait so long?
Because T4 takes a little bit time to actually build up a steady level because of a long half-life. So therefore, it does take a while.
So you also tell the patient not to be too impatient about improvement of symptoms?
Yeah, but suppose in this case, if they are asymptomatic, then it won't be a problem.
Yeah,
if they are symptomatic, you just tell them, look, it takes 4 to 6 weeks, so be patient.
All right. So I think there's another question here that is asking about patients who stopping treatment. How do you try and maintain to ensure that they are taking treatment? So I'm not sure, it's not very clear. Euthyroid patients treatment, they tend to stop their medication. I wonder, Dr. Cole, whether they're asking about thyroxine treatment or talking about anti-thyroid therapy. But if it's thyroxine, yeah, if the patient is on thyroxine, like the patient that was presented who's hypothyroid, you really, really need to sit them down and explain to them the consequences of not taking thyroxine, that they will be hypercholesterolemic, that they will have a high risk of developing premature atherosclerotic disease. If they understand the consequences, then obviously it's going to be something that they are more likely to abide by taking the medication. But again, if you explain to them that thyroxine has got an extremely long half-life of 7 to 8 days, if you miss an occasional dose, you will not feel different. And if they understand that, then they will recognize why, not taking the medicine 1 or 2 days doesn't mean that they don't require the medication, right? And in fact, one of the key tips that we tell our patients is thyroxine is very forgiving. If you forget to take it today and tomorrow, you can actually make up the dose. Okay, that's another question that we are supposed to have a look at. Jaya, would you like to read that out? I haven't seen it.
Okay, it is somebody with fast AF and BP is borderline. What would you prefer? Beta blocker, rate control CCB? Beta blocker or rate control CCB is contraindicated. So they want you to choose between amiodarone or digoxin. I'll make it very fast. I would choose amiodarone IV and Cole, just one word answer.
Yeah, amiodarone.
Okay, fine. In the interest of time, I think we may have to move on.
I'm not sure that I want to go on anymore. You can actually. Do you
Yes.
want?
No. The QR code.
Yes,
Finishing.
you have to share this. Yeah.
Okay. Say thank you.
Oh, thank you. Okay. I didn't know I was supposed to end, man. I wasn't ready to end. Okay. Thank you very much for attending our session. We are close to finishing. I'll pass the floor back to Dr. Allen, and he will take it over.
Okay. Thanks very much, colleagues. Well, here comes the part. I know there are some of you have a webinar for GPs at 3 to 5 on the COVID vaccination. So here's the QR code for CPD points. We'll leave it on for a while. Please use your other device to scan. Hopefully, if you are just watching in one device, you can email it or WhatsApp it to somebody else, and then you can snap it with your MMA events app. Okay, the code will be valid for about an hour. You can either pause the video in case you're scrambling around, or you can rewind and play it again, but I will leave it on for some time. So in interest of time, we promised to finish by 3. It's almost 3. So thank you everyone for another exciting SJMC Grand Round, and thank you all for watching. Have a good weekend, everybody. I'll leave it on full screen for the QR code. All right. Thank you.
Thank you very much.
Thank you very
Thank
much.
you. Thanks. Okay. Finished.